Chapter 24 of the 2018 Diabetes Canada Clinical Practice Guidelines is on screening for the presence of cardiovascular disease. My name is Alice Cheng, and I am narrating this deck on behalf of Paul Poirier, Oliver Bertrand, Jonathan Lipchick, John Mancini. Key changes from this chapter include updated information on when to perform a baseline resting ECG in people with diabetes, as well as new information on the role of coronary artery calcium scoring. The checklists for screening for cardiovascular disease include: screen with baseline resting ECG in select people with diabetes at the time of diagnosis. Stress testing for people with diabetes with symptoms or other associated diseases is appropriate, and refer people with diabetes with inducible ischemia to a cardiac specialist. The reason why this chapter is necessary is because we know that myocardial infarction occurs at a younger age among those with diabetes. The solid lines represent individuals living with diabetes. The y-axis are the number of events per 100 person years in terms of myocardial infarction, and the x-axis represents the age group. Now, as mentioned, the solid line represents those living with diabetes, and the dotted lines represent those who do not have diabetes. And you can see that the solid lines are much higher than the dotted lines, meaning that myocardial infarctions are occurring at a younger age among those living with diabetes. Therefore, who should be screened with a resting ECG? If you're age over 40 or have a duration of diabetes greater than 15 years and age over 30, or if you have any end organ damage, you should receive a screening ECG. The good news is that those first three criteria are identical to the recommendation for using statin therapy for vascular protection. Other things that would make you get a baseline ECG include having more than one cardiovascular risk factor, or being age over 40 and planning to undertake very vigorous or prolonged exercise. In individuals such as that, a baseline resting ECG is appropriate, and the ECG should be repeated every 2 years, looking for Q waves or STT abnormalities or other abnormalities on the ECG suggestive of coronary artery disease. Who should have stress testing and/or functional imaging to screen for coronary artery disease? Well, if a patient presents with typical or atypical cardiac symptoms, or if they have associated diseases such as peripheral arterial disease, carotid bruits, transient ischemic attack, or stroke, or patients with resting ECG abnormalities such as Q waves, those individuals should undergo functional imaging, which typically would start with exercise ECG stress testing. However, if they are unable to exercise or their resting ECG is abnormal, then other options include pharmacologic stress echo, pharmacologic stress nuclear imaging, or other imaging techniques depending on local expertise. Who needs to be referred to a cardiac specialist? Anybody demonstrating ischemia at low exercise capacity on stress testing, such as less than 5 METs, would be appropriate to be referred to a cardiac specialist. Recommendations for this chapter include: number 1, a resting ECG repeated every 3 to 5 years should be performed in individuals with diabetes with any of the following: age over 40 years, duration of diabetes greater than 15 years and age over 30 years, end organ damage being microvascular or macrovascular, having more than one cardiovascular disease risk factor, including current smoking, hypertension, family history of premature CVD and first-degree relative, CKD, obesity, or erectile dysfunction. Alternatively, being age over 40 and planning to undertake very vigorous or prolonged exercise, such as competitive running, long-distance running, or high-intensity interval training, would also be appropriate to then do resting ECG repeated every 3 to 5 years. Recommendation 2. People with diabetes should undergo investigation for coronary artery disease by exercise ECG stress testing, if capable of exercising, as the initial test in the presence of any of the following: typical or atypical cardiac symptoms, such as unexplained dyspnea or chest discomfort, signs or symptoms of associated diseases, such as peripheral arterial disease with an abnormal ankle brachial index, carotid bruits, or transient ischemic attack, stroke, resting abnormalities on ECG, such as Q waves, or a calcium coronary score of greater than 400 Agatston score. Recommendation 3. Pharmacological stress, echocardiography, or nuclear imaging should be used in individuals with diabetes in whom resting ECG abnormalities preclude the use of exercise ECG stress testing, for example, left bundle branch block or STT abnormalities. In addition, individuals who require stress testing and are unable to exercise should undergo pharmacological stress echocardiography or nuclear imaging. Recommendation 4. Individuals with diabetes who demonstrate ischemia at low exercise capacity, defined as less than 5 metabolic equivalents, on stress testing should be referred to a cardiac specialist. Key messages from this chapter include: compared to people without diabetes, individuals with type 1 and type 2 diabetes, especially women, are at higher risk of developing heart disease and at an earlier age. A large proportion will have no symptoms before either a fatal or non-fatal myocardial infarction. It may be desirable to identify people at high risk for CV events, especially people with unknown established severe CAD. In individuals at high risk of coronary artery disease, based on age, gender, description of chest pain, history of prior myocardial infarction, abnormal resting ECG, and presence of several other risk factors, exercise stress testing is useful for the assessment of prognosis. Exercise capacity is frequently impaired in people with diabetes due to the high prevalence of obesity, sedentary lifestyle, peripheral neuropathy, both sensory and motor, and unknown vascular disease. For those unable to perform an exercise test, imaging testing such as pharmacologic nuclear stress testing, stress echocardiography, coronary artery calcium scoring, or coronary CT angiography may be required. Most imaging techniques have been shown to be useful in prospective study in order to identify people at higher risk. However, there is so far no head-to-head study showing which one will be best in a cost-effective way. Key messages for people living with diabetes. People with diabetes are at increased risk for developing heart disease and often present at an earlier age than people without diabetes. Therefore, discuss with your healthcare provider your symptoms, especially if you have chest discomfort, shortness of breath while exercising, or palpitations, and also discuss with your healthcare provider how to screen for heart disease. For more information on this chapter and others, please visit guidelines.diabetes.ca or download the app on Google Play or App Store. Thank you very much for your attention.